PPT
ಅಲ್ಲ ಅವ್ರಿಗೆ ಕೇಳಿಸ್ತಾ ಇದೆಯಲ್ಲ ಅಂತ ಒಂದ್ಸಲ ಚೆಕ್ ಮಾಡ್ಬೇಕಲ್ವಾ?
ಮಾಡಿ ಸ್ಟಾರ್ಟ್ ಆಗಿದೆ.
ಚಾಟ್ ಆಗಿದೆ ಈಗ. ಹಲೋ, ಕೇಳಿ ಒಂದು ಕರ್ಕೊಂಡು ಬನ್ನಿ ಬೇಗ ಕರಿ. ಹಲೋ, ಆಮ್ ಐ ಆಡಿಬಲ್? Good morning all. So we will start the class. So the topic for today's class is cancer vulva. Okay, good morning everyone. Hello, ಇದು correct ಇದೆ ಅಲ್ವಾ? Correct. Okay. So good morning everyone. Today's topic is cancer vulva. So cancer vulva, it's a relatively a rare cancer. So we are taking its incidence according to the incidence of other gynecological malignancies. So if we take like 100 gynecological malignancies, then cancer vulva will account only for 3 to 5%. So its incidence is a bit rare than the other malignancies. So if we consider female genital tract malignancies, then it is fourth most common malignancy. Though, so you all know that first malignancy in female genital tract is CA cervix. So its incidence is in the later part of life. Around women should be aged more than 65 to 70 years. So its incidence increases with increasing age. So same as cancer cervix, even cancer vulva is also in high association with HPV serotypes, that is human papilloma virus. So in that we all know that type 16 and type 18 are high risk for causing cancer cervix. So same viruses are involved in cancer vulva also. So whenever cancer vulva is suspected, so we should also see that whether cancer cervix is also associated with it. Now we will start with the anatomy of vulva. So what all structures are involved? So this is a picture of vulva. So what all structures are involved? So vulva includes mons pubis. This is the area. Then it includes the clitoris. Then it includes the two labia majora. So these are the two labia majora folds. You all can see the thin fold. This is the labia minora. Then this is called the posterior fourchette. Then the distance between the posterior fourchette and the anus is called, this distance is called perineum. So here comes your urethral opening. So all these structures combined together form the vulva. So when we are dealing with anatomy, so we will finish off with the lymphatic drainage of vulva, which is very important because we are dealing with a case of cancer vulva. So and it most common it spread is through lymphatic drainage. So what is happening here? Majority of the lymph nodes, they are draining from labia majora, anterior part of labia majora. They are all draining to the superficial inguinal lymph nodes. From superficial inguinal lymph nodes, it goes to the deep inguinal lymph nodes, then the femoral nodes. Then from there, it will drain to pelvic nodes. So what are the pelvic nodes? So in that comes your external iliac group. See here. This is the external iliac group, and then you have the obturator nodes, then comes the para-aortic nodes. So let me repeat it once again. So all
Ma'am,
the
we can't see
lymphatic,
the slides, ma'am.
you cannot see.
No, ma'am, we can't see the pictures, ma'am. We can only see cancer vulva.
Okay, let me check out some technical problem, I think. Close ಮಾಡಿಲ್ಲ ನಾನು ಇಲ್ಲ close ಮಾಡಿಲ್ಲ. Can you all see now? Hello? Hello?
Yes, ma'am.
You can see the slides?
Ma'am, we can see, ma'am.
Okay, the slides are moving. Can you see it now? The pictures? Okay?
Yes, ma'am.
Okay, okay. So, did you see the first picture then? The anatomy of vulva. So, let me repeat. So, vulva has all the structures which includes mons pubis, labia majora, then you have the clitoris, then you have the two labia minora, then the fourchette. The distance between the fourchette and the anus is called the perineum. So all these structures, then you have the urethral opening here. So all these structures constitute the vulva. So now coming to the lymphatic drainage of vulva. So most of the lymph from the vulva, it is drained to superficial group of inguinal lymph nodes. From superficial lymph nodes, it is drained to the deep inguinal lymph nodes. Okay. Then from deep inguinal lymph nodes, it goes to the femoral nodes, and then it goes to the pelvic nodes. So in pelvic nodes, you have the external iliac nodes, and then you have the obturator nodes. Then from there it drains to the para-aortic nodes. So what is important about this lymphatic drainage is, See, can you see here? There is crisscrossing of the lymphatic drainage. So some of the lymph from the left part of the vulva can also get drained to the right side inguinal group of lymph nodes. This is important for us when we are studying the spread of the malignancy. So this crisscrossing, especially the crisscrossing is happening more so when the tumor is in the center than when the tumor is in the lateral part of the vulva. So lymphatic drainage of vulva is very important. So and most important is superficial inguinal nodes. It is also considered as sentinel node. We all know, no, whenever we biopsy a sentinel node and if it is found to be negative, even whenever we are doing any cancer surgery for cancer, so if it is found negative, then we are relieved that the cancer would not have spread more beyond superficial inguinal nodes. So superficial inguinal nodes are considered as the sentinel node. So blood supply to the vulva is mainly by the internal pudendal artery, which is a branch of internal iliac artery. So now coming to the vulva cancer. So we all know in cancer cervix it is divided into CIN and invasive cancer. So same thing is happening in vulva cancer also. So here we have something called pre-invasive lesion and then the invasive vulval cancer. So pre-invasive lesion, we all know the terminology itself, it is self-explanatory. It is nothing but here the dysplastic or the cancer cells are limited to epithelium only and it has not breached the basement membrane. So these pre-invasive lesions are again divided into cancer usual type VIN and differentiated VIN. So what is the difference between these two? So cancer usual type VIN is nothing but it is related to human papilloma virus and differentiated VIN is not related to HPV. So VIN is nothing but vulval intraepithelial neoplasia. It is nothing but the dysplastic cells present only to the epithelium and is not breaching the basement membrane. So to this category, we also have other diseases like Bowen's disease, Paget's disease, microinvasive cancer and melanoma in situ. So the Bowen's disease, it is nothing but a slow growing malignancy of the vulval epithelium. Paget's disease, it is nothing but it is similar to intraductal carcinoma of the breast. So why it is present here in the vulva? Because vulva has apocrine sweat glands. So Paget cells are nothing but they are adenocarcinoma mucus secreting cells. So this Paget cell is also one of the intraepithelial neoplasia. So these are some of the pre-invasive lesions. So among them important is for us is which is related to HPV. Most commonly it is associated. So what is the prognosis? So vulval intraepithelial neoplasia can be found even in young patient also and most of the times it is related to HPV and it has 90% regression rate. So it will be spontaneously cured on its own most of the times in young patient. But in old patient it is related to lichen sclerosis. So what is this lichen sclerosis? And it has whenever it is associated with lichen sclerosis and in old patients, it has the chance of progression to invasive cancer. So this lichen sclerosis is nothing but they are vulval dystrophy. So they are benign conditions of the vulva. Lichen sclerosis is nothing but when the woman attains menopause, estrogen is not there. So the vulval epithelium becomes thin and atrophic. So such condition is called lichen sclerosis. It is one of the vulval dystrophy. So other important vulval dystrophy which I have to mention here is leukoplakia of the vulva. Leukoplakia here what happens? In lichen sclerosis there is atrophy whereas in leukoplakia there is hyperplasia of the vulval epithelium. So old patients and those again related to lichen sclerosis have higher progression to invasive cancer. So now we have finished pre-invasive lesions. Now we will come to invasive lesions. So among invasive lesions, we all know that it's the squamous cell carcinoma which accounts for majority of the chunk. Around 90% of vulval carcinoma are squamous cell carcinoma. Rest 1% will be shared with melanoma adenocarcinoma, sarcoma, basal cell carcinoma, or the rodent cell cancer. So majority of cancers which we encounter in vulva will be squamous cell carcinoma. So all these are predisposing conditions for vulval pre-invasive cancer. So same predisposing factors will also be present for CA vulva also. So the factors are same. So what are the factors? Chronic vulval irritation, any sexually transmitted diseases, and dystrophies. I told you vulval dystrophies, it comes in benign conditions of vulva, which mainly comprises of leukoplakia, that is hypertrophy of epithelium, and lichen sclerosis, which is atrophy of the epithelium. Then we have the obesity, diabetes, hypertension, which are all risk factors for vulva, VIN or vulval cancer. Then prior squamous cell carcinoma of the cervix, vagina, or the anal rectal area as well, and then vulvar dystrophy probably increases a woman's risk. Other immunosuppressive conditions like HIV, even pregnancy is also included in this. Then last comes the smoking. So all these are predisposing factors for VIN as well as invasive vulval cancer. So, well, VIN is not diagnosed macroscopically. That is, by bare eyes, we cannot diagnose VIN. So, what we have to do is only we can take the biopsy of the suspected area, and then what do we see there on histology? Definitely, there are dysplastic features like loss of polarity, stratification, dystrophic changes confined to epidermis, and important thing is basement membrane is intact. So, these histological feature will be found when we take a biopsy of the lesion. So clinical feature, usually those women who are having VIN will be asymptomatic most of the times. Even if symptoms are present, they will come with pruritus. So that's the first symptom. Then later they will present with soreness, dysuria, and dyspareunia. Then the lesions could be single or could be multiple. It could be spread all over the vulva, or it could be warty or papular. So it can vary single to multiple, warty or papular. So these are the symptoms with which the patient presents to you. So I told you VIN is not diagnosed by bare eye examination. Biopsy is a must. So when you do a biopsy and you subject it to histopathology, I have mentioned all the features. So loss of polarity, dystrophic changes, mainly confined to basement